less and less part of the picture. Most of my colleagues, if they made any kind of error or mistake with me, they didn't do so because they were doing me any ill will. It was because I think they cared for me. They didn't want to accept the fact that I could be mortally ill, because I was, in a sense, so closely identified with them. And I think that there are many stories throughout the medical profession that will support this notion that doctors cannot be totally objective with other doctors. And this is not out of fear of malpractice. Sure, all of those things are there, but what is the primary thing is the notion that somehow I, as a physician, have failed to conquer death in this situation. And I have, as a result, failed, and therefore I must, in some fashion, move to a more defensive stance.
His liver function is extremely poor. His synthetic function is extremely poor. We don't know what his metabolic function is. You really do.
Several years ago, Dr. Nathan Cherney successfully overcame cancer. His experiences as a care seeker gave him a broader insight into the needs of his own patients and of his responsibilities as their physician.
I was fortunate enough to have a cancer which was eminently curable. And in a sense, I didn't face many of the existential distresses that a lot of my patients are confronted with. My post-operative pain control was a terrible experience. I can vividly recall waking up in the middle of the night in terrible pain and being told that my next injection wasn't due for another 2 hours and I just have to wait it out until then. I hurt terribly. I didn't understand this. I thought there was an injustice and an insensitivity to it. And if anything positive came out of that experience, it was an appreciation of the importance of the care and sensitivity with which I was cared for by the nurses who had to try to nurse me through what was, I'm sure, a very distressing experience for them as well. For a long time, the emphasis in medical education has been on what's been so-called the biological model, that doctors have been taught about anatomy, about disease processes, about pathology, and people would come away with a very clear impression that their role as a doctor was to treat diseases. I think that this has been to the exclusion of looking at the notion of the person and the wider notion of suffering. I guess my attitude is fundamentally that I think that patients have a right to be free of pain, and that there is the moral corollary of that as a duty of care that falls upon the medical system to provide that comfort.
Western medicine has traditionally focused on the science of treating disease rather than the art of treating the whole person. But if the role of the doctor is changing, does medical education adequately address this broadened scope?
Maybe that's the biggest problem with medical education. It's what's not talked about, what's not done. In other words, that people tend to avoid the painful, frightening, horrifying experiences. They don't know how to deal with it. Your instructors don't know how to deal with it. And you may go through an experience as a student or an intern dealing with people who are going through awful procedures or illnesses, and nobody talks about it. It's just handled in a very technical manner.
You know, the old medical student pun about being in the pre-cynical and the cynical years, and I think it often is the case that by the time students have completed medical school, that we have conditioned them to be pretty cynical, pretty distanced, pretty depersonalized. What influences our teaching has to do with how, as a society, we see not only illness, but wellness and life itself. There is such a clear expectation in our society that cure, good health, and happiness are part of our constitutional right. And where that's the norm, that's the expectation, then illness is an affront. Somebody made a mistake here. You know, how different from the worldview that sees illness and health as part of the experience, part of the journey.
We spent $801 billion on medical care last year. I don't think anybody in this room feels like they're getting their money's worth. What is the missing ingredient? What I believe is missing is the ingredient of humanity, has slowly but surely drifted away from medicine. And what we need to do, both by personal experience and by our own dealings with our colleagues, is how do we recapture this? How do we get what is really important in medicine back into the experience?
There's another question about
Dr. Kathleen Foley, Chief of the Pain Service at Memorial Sloan Kettering Cancer Center in New York City, teaches physicians from all over the world how to better manage pain in their patients. Part of this process is learning to cope with the pain of attachment that many of them experience in ministering to the terminally ill.
We ask that question often of each other, of why we do what we do, why we care, why we think we should think this is an important issue, and also how we can tolerate doing this all the time when you see significant pain, when you see suffering. And I think my own perspective is I think we really do help patients so that you have the gratification of at least relieving their pain. You have the gratification of trying to make it better, although we don't always make it better. And I think we importantly share the responsibility of caring for the patient with a variety of other people, with a team.
Each morning, Dr. Foley meets with her pain fellows to discuss the progress of each patient under their care.
She was diagnosed with lymphoma in March of 91. Her biggest problem was profound sternal squeezing pain, to the point where when I went in to see her, she was the only position of comfort was literally hunched over. If she leaned even back as far as this, she said she had this horrible choking sensation with this really wrenching feeling in her sternum. Her daughter had a recent suicide attempt in the fall related to her mom's illness. Has tremendous amount of difficulty coping with her mom's illness. She said that she's always shied away from psychiatry in terms of it being a label that she found difficult to relate to. But when we also spoke about talking about it, she says she always feels a lot better when she does speak to someone.
I do think that achieving some degree of trust and intimacy is important. I think, however, for some physicians, it becomes threatening as well, because if one is constantly forming intimate relationships which are then going to be lost, not everyone can adapt to that.
Most doctors, I think, fear failure with the patient, but they can't accept that perhaps the patient has to die. The patient may not respond to their medication. They're unable to offer the patient something else. They're only able to offer the patient the protocol of the day. Instead of sitting down, talking to the patient, listening to the patient, offer them something of themselves.
I think sometimes medical people have been taught, the idea that, empathy to a point, but you still have to remain distant. In fact, some of the nursing staff have been saying that to me, on the floor where I'm working now. And that's true, but I think that can be a cop-out. I think you have to still let yourself really feel, and it means sometimes you're going to feel bad. That, I think that's part of what goes with the territory if you're going to be a sensitive medical practitioner, is that sometimes you are going to feel bad about what's happening with somebody, and that you shouldn't try to block those feelings out. It was the rare nurse, and actually it was one nurse in particular that stands out to me, who was a woman closer to my age, who had younger children, who, was able to say to me, I understand that this is really awful for you. If this was happening to one of my children, I don't know how I could stand it. And that meant so much more to me than these people who were so perky and acting as though, we're just sort of going with the program here today. I mean, that somebody was able to tell me, I know you're hurting.
Some of the doctors, they'll make great researchers or whatever. They are never going to get the message. And then you can see some young man who doesn't seem to have any special reason, but he's got it. He has that ingredient of humanitarian understanding. And for him or her, it may not be as great a challenge because it comes easier, but it's there, and it's extremely important from a therapeutic point of view.
I think that's an important part after you master the disease part, which you will master as you know during residency, at least to some degree that you can administer care, is to start to evolve your empathy, and that comes from having your hand on the shoulder of the patient when they're going through a test, and let that patient teach you what that test means or what their illness, what their pain is, etc. And that probably takes a lifelong course to fully appreciate it. I feel at the end of my residency, I started to think about it and started to live that way in relationship to my patients. And I started talking to my other colleagues about it, and then I realized other people were looking at it too. And I said, "Wow, this might be what it's all about," and being a physician.
For many patients, the prospect of pain can be as terrifying as the disease itself. But doctors can treat pain, even when they can no longer treat the underlying illness.
What we've been stressing is to ask the physicians to start with the fact that they believe the patient's complaint of pain. I mean, that's the cardinal rule, that you start with believing the patient's pain. For the group of patients with advanced disease, oftentimes pain as a symptom becomes the disease. I'm an advocate of teaching patients the concept that they don't have to be in pain.
I was doing well, and all of a sudden, boom, I developed this tremendous pain in my leg. Pain that I didn't sleep for 6 nights and thought that was it. I couldn't come out of my disease. I was in so much pain that I couldn't live for the day. And I thought that was it. So I said to my father, after 6 days of not sleeping, I said, it's time to call Kathy Foley.
Okay. What about your foot? How's the pain been?
Well, I haven't had any pain since I went to not weight bearing on the foot. So
Okay, so as long as you're on the crutches.
so as long as I'm on the crutches, I have no pain.
Terrific. Peter has responded, and he hasn't had escalating pain. So his degree of pain relief is enormously impacts on his quality of life. And I think so importantly that he doesn't have to focus on his disease.
There's still all kinds of old attitudes about pain in the hospital. One sees it, for example, if the hospital gets under strain at night, too many patients, not enough nurses, then the nurses have to make the priorities. Are they going to take care of the patient who is suffering with breathing problems, or are they going to take care of a patient who's suffering with pain? All of the terrors that the patient has been dealing with through the day or through the night focus down on, I didn't get my pain pill. But most importantly, there needs to be a spirit of cooperation, collaboration, and understanding that exists from the top of the treatment team down to the bottom layers. And people are working together to try to get this patient improved rather than people acting out whatever their particular conflicts are around their professional identities or their happiness or unhappiness with the system.
In the case of children with critical illness, it is their parents who must advocate for them. This can generate enormous conflict between doing what is best for their child and what is least painful.
Every time they needed blood, which was very frequently, they would do a finger stick, which is really not a small thing. I mean, it seems like it might be a small thing, but I think even most adults are really very afraid of having their finger poked like that. And I was in the room when a lab technician the first week came in to get the blood, and I really thought I couldn't stand it. I mean, absolutely couldn't stand it. And really just thought he just can't go through that. So we spoke to our oncologist, and we asked him if their